It's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
I'd like to talk to you today. Thanks so much for inviting me, by the way. I'm really grateful to BJC. I love talking about migraine and treating migraine, and it gets me out of bed in the morning. I hope that from my presentation, you'll get a bit of a feel for it. I work mainly in private practice. I have a practice with my dad called Spiro Neurology, and Dad and I both treat migraine. I learned a lot about what I know about migraine from my father, and some really great mentors I had in my training at Prince of Wales Hospital as well. And I also do a bit of research at UNSW. So tonight's talk is going to sort of be structured like this. I went with what the BJC team thought would be good for everyone. And I just tried to think through how I was going to do that best. So firstly, I want to share with you why I care about migraine and why I think everyone should care about migraine. Then what is migraine? What happens in the brain during a migraine attack, and how do our medical treatments for migraine work? What can every migraine sufferer do to manage their migraines better? And how can a patient get the most out of working with a neurologist to better their care and treatment? So now, a bit of a biased question given the topic of the talk, but if you had to look at all of these neurological diseases and everything that you know about life, which would you anticipate would cause the most burden of disability worldwide? Just have a think about it. And of course, just like in any multiple choice test, the answer is always C, it's migraine. It is a disease, it might surprise you to think of it that way. I think if you look at these other diseases, some of them are known to be very disabling conditions, but migraine operates for the longest, except maybe epilepsy, over a person's lifespan. It is also something that affects them for a large proportion of their life, in terms of how much of their time is taken up by having a migraine. And it is incredibly disabling. I have patients, some of my patients are as disabled during a migraine attack as another person would be during a stroke. That's, of course, like the pointy end of things, but a lot of people are very severely disabled, can't do their normal tasks. So if you add that all up and how common migraine is, it is actually one of the leading causes of years lost to disability worldwide. There is a big survey of all epidemiological data in the world regularly looking at years lost to life versus years lived with disability, and it consistently ranks in that top 5. Sorry, I'm just going to move where I can see everyone a little bit because it's making it hard for me to see my slides and talk. Just 1 second. And it doesn't matter what country you look at in the world, how economically developed that country is, the same thing holds true across the board almost entirely. And if you look at what the leading causes of years lived with disability are in the world, it would really surprise you. So in men, these are the most disabling conditions in the world. The top part is for all men and the bottom part is for young men. And as you can see, low back pain is the most disabling condition for men worldwide in terms of causing years lived with significant disability. And the other things are all things that we think of as pretty common disorders in men. And they are disabling, they are difficult. And migraine is up there as the 4th cause of years lost to disability in men of all ages and the 2nd in young men. And then in women, you get migraine ranking even more highly. So the 2nd in women of all ages and the most disabling in young women. And in everybody, migraine sort of ranks 2nd most disabling condition on the last survey. But every year that when they do it, I've never seen it fall below number 5. And in the last few surveys, it's always been above number 3. And how does this affect individual patients? So these are just some quotes from patients of mine that I think really demonstrate how this disease affects people's life. So this is a patient of mine, Sharon. All the names have been changed, but the words are real and the other things about the patients are real. So this lady has type 1 diabetes. managed to go through a whole pregnancy with type 1 diabetes, injecting insulin with the tightest control. She's been dealing with this since she was 8 years old. And when it was time to have her second baby, she didn't want to because her migraines were so out of control. And this is after we've been working with her migraines for about 6 months, towards the end of her first pregnancy and the beginning of her baby's life. And this is not a sentiment that I hear uncommonly from women who just don't feel well enough to contemplate having one or more children. I'm pleased to report that she's much better and she's trying to have a second baby as we speak. But that's just to give you an idea, such a patient that's so used to chronic illness, just struggling with the burden of the disability caused by their migraines. This is interesting, and you have to forgive me for the language in here, but I just wanted to show you as well what it's like for men, because a lot of people with migraine are men. It is more common in women, but this just really illustrates the kind of toxic masculinity culture this time that gets leveled at men in the workplace who have pain disorders, and migraine in particular. I actually saw this patient today, and every time I see him, he says something really sad about how he gets bullied at work. He's much better, but he still really struggles with the dynamic in his office, in this really like very high achieving, hardworking male culture that he works in. And this sort of leads into my next section. So this is a patient I saw probably 3 or 4 weeks ago. And she said to me, I wish more people understood the difference between having a headache and the migraines that I experience. And she was just so relieved at being in a space where somebody understood that, because it wasn't something she was used to hearing. So that sort of leads me into this part, which is what is migraine? Well, migraine is not just a headache. A headache is a common symptom. So a lot of people will say things like, oh, you've got a migraine, here, have a glass of water, sit down, relax. Maybe you should work on your stress levels a little bit. But the thing is, having a migraine is not the same as having a hangover. It's not the same as not sleeping enough or being a bit dehydrated, which is when a lot of other people may experience far less severe headaches. Headache is a symptom, but migraine is a disease, and it's one of hundreds of known headache disorders. We have a manual that sort of helps us as neurologists sift through headache disorders. So headaches are divided up in this way in our headache classification index, and there are so many headache types, even I can't possibly remember all of them. Even the people that wrote the book can't remember all of them. So what I do when I'm listening to a patient's story is I'm sifting through, is there anything that sounds dangerous about this headache? Is there anything that gives me a clue as to the diagnosis underlying this headache? And I'm trying to sift them through this. So a primary headache disorder is a disorder like migraine or tension type headache. Those are the two most common ones. It's a headache that happens because of things that you can't see, identify, and that are not going to kill you. So they're headaches that happen for physiological reasons rather than for anatomical reasons. A secondary headache is, I have a headache because I'm taking a medication that gives me headaches, or I'm having a headache because I've got a tumor in my head, or I have a headache because I have dry eyes. So those are the sorts of things that, there are many different causes, or I have, meningitis. So secondary headache is headache because of a thing. And we're always on the lookout for signs that this headache could be a secondary headache. And then facial pains or atypical facial pains could be either primary or secondary. So they're things that I need to usually do some tests to work out. And as well, there are a lot of stories I hear. I'm like, it's probably migraine, but there are a couple of atypical features. I'm going to do an MRI on this patient and just check that it's not a secondary headache. And then there are terms like acute and chronic that get thrown around as well. So most headache disorders are what we think of as chronic medical conditions. They affect people for a big chunk of their lives, so years or so of their life. But in headache speak among neurologists, the headache is given the medical term chronic when it's present for more than half the days of the month. Otherwise, we call it an episodic type of headache. So if you have migraine and it's chronic migraine, what that means is that you have headache 15 or more days of the month, and at least 8 of those days are migraines rather than other types of headache. we've been trying to figure out what headache is for a long time. These are just some ancient sources. So we've got here trepanation, which there are lots of prehistoric skulls that have been found with pieces taken out of them. And in fact, trephines are one of the most common ancient medical tools that we have. When people believed that headaches were caused by spirits that lived inside people's heads and would actually take pieces out of the skull to relieve pressure. So this is the first neurosurgery that was done probably for headache and epilepsy as well. There's an ancient papyrus which describes unusual treatments for facial pains. And then Hippocrates actually just described one of the most, did a beautiful description, and the first description in Western medical literature of visual aura of migraine. And Galen described the pain of migraine and nausea in such a good way that we haven't really moved past his definition very much. So if we're going to talk about what migraine is, I guess this is what it sounds like to me. We've got official diagnostic criteria that are useful in research, but in practical terms, in day-to-day life, I think of it as severe pain that's on one or both sides of the head, neck, or jaw, which is throbbing, present for a prolonged period of time, so hours to days, and in which there is also not just pain, but neurological dysfunction, which can consist of visual distortion, light, sound sensitivity, smell, heightened sense of smell, and other sort of sensory distortions. Nausea and vomiting are often present, and the headache is usually made worse by activity or changes in posture. During a migraine attack, there's abnormal, in terms of what we now understand about the science of migraine, it starts with abnormal brain activity that then activates the trigeminal, so the nerve that supplies pain and temperature sensation to the face, the trigeminal and cervical nerves, so the neck nerves. Then CGRP is released from the endings of the trigeminal nerve and blood vessels expand. So I'm just going to go through that step by step. So with the abnormal brain activity, it starts deep in the brain where there's reduced alertness, fatigue. So the deep brain activity can cause a reduced alertness, fatigue, or agitation. There's also the pain map of the whole body, in which the head and neck are a single structure that activates. And sometimes in some patients that can cause sensitivity of touch. So touch feeling painful on the face or scalp. For some people, it activates the emotional center. And so before a migraine, they might notice they're a bit moody or agitated. I have one patient whose wife can tell he's going to get a migraine up to 3 days before he has his first pain, because his behavior just subtly changes. This is also the part of the brain that increases a patient's sensitivity to smell. And also the gut, the enteric nervous system that controls the gut is there. So often the gut can become paralyzed and patients may start to experience nausea or diarrhea in this phase. Now, not all patients get all of these things, but they often do. And often yawning is present, and also thirst and increased urine production. This can happen up to days before the migraine actually starts. Then that abnormal electrical activity spreads from deep in the brain to the surface of the brain, and currents of electricity just slowly creep around. And this is when we start to see higher order thinking problems. Some patients have issues with speech and movement, but many patients have sensory distortion. So they may get formed visual sort of psychedelic things that they see, colors, zigzags, lights. They can experience sensitivity to light, sound, or increased balance information that gives them a sense of disequilibrium or even vertigo in some patients. Then the trigeminal and cervical nerves activate. So the trigeminal nerve provides pain and temperature to the skin, to the inside of the mouth, to the inside of the sinuses and the surface of the eyes. So any of those areas can start to hurt. Some patients, or many patients who get chronic migraine or high frequency migraine, also often have tooth grinding. That's because the trigeminal nerve supplies the muscles of chewing. And a jaw pain can be a problem for some patients. And also most patients having a bad migraine will look pale, and that pallor is caused by changes to the autonomic nerves to the skin, which is also part of the trigeminal system. Some patients get sinus or nasal congestion, their nose running or tearing. It's less common, but it's definitely possible. The cervical nerves supply the back of the head, the neck, and the shoulders with pain, and also with some motor activity. And those areas can become tense. And many patients in the days leading up to a big migraine will actually have an increasing sensation of neck tension. They then feel is traveling up to their head and causing the pain. A lot of patients have a very stiff neck during an attack because of this. So then the last phases are that those nerve endings secrete a hormone called CGRP onto blood vessels. The blood vessels expand and start to throb, and that causes that horrible throbbing pain of migraine. After an attack, because of all of that abnormal brain activity, the brain's depleted of essential chemicals called neurotransmitters that are responsible for all the day-to-day housekeeping that the brain does, because the loads have been released during the attack itself. And so many patients experience a feeling of being really unwell and washed out after a migraine that can persist for up to 48 hours, or some people have even more prolonged ones if they have particular types of migraines. And a lot of patients call this their migraine hangover because it feels very similar to a hangover. How do all these physiological things that are going on come to a patient? Well, we think of it in phases. So there's the prodrome, which is where you get that deep brain activation, the emotional things, the thirst, the urination, the yawning. Then you can get the aura. Not all patients have aura, but some patients do. And that is usually a visual phenomenon, but can also be motor, sensory, or involve other sort of higher order brain surface kind of activity issues. Then you have the headache itself, and nausea and vomiting is often part of that. And then you have the postdrome, or the migraine hangover. So even though the migraine itself will last 2 to 72 hours of pain, the patient can have neurological disability, which can last days longer than that. I'm only talking about medications at this point, not because non-medication things are not important, but it's really easy to understand how the medicines work just when you've got all of that science fresh in your mind. So the paradigm at the moment in migraine is that we've got medicines you can take every day to prevent them from happening. Only some patients need this. So patients who are getting migraine 4 or more days a month generally should be on a preventative, or patients with extremely severe attacks that are very disabling, might cause paralysis down half their body, that kind of thing. Even if they're infrequent, they should be on a preventative. And then you've got acute medications. So those are the medicines you take once you have a migraine already to treat those attacks which have already started. And just going back to that sort of process that I was describing, these are where our medicines work. So most of our medicines were discovered accidentally. They weren't intentionally developed for migraine. They were developed for depression, epilepsy, heart, blood pressure control. One is Botox, which was accidentally discovered by being used for cosmetic purposes and improving migraine in some patients who were using cosmetic Botox. And then we do have some drugs like CGRP blockers and standard migraine that were developed specifically for migraine. But this is where they work along the process. So the antidepressants, antiepileptics, some of our supplements, and a new vagus nerve stimulator all work to reduce the abnormal brain activity part. The trigeminal and cervical nerves are impacted by Botox and less likely to fire off in the presence of Botox. Botox also is transported back into the rest of the brain to reduce the abnormal brain activity part a little bit as well. CGRP hormone is blocked by actually 2 new classes of drugs. So we've got CGRP antibodies in Australia, but there are also overseas, and I hope they soon come here. There's a whole class of small drugs that you can take via a tablet, either for an attack or as a preventative, called Gepants. And also Sandamigram, which is a very old drug, works around the CGRP hormone release side. And then you've got the tablets that work to prevent that abnormal blood vessel expansion, like beta blockers and Candesart. And then you've got the things you take when you have the migraine. So a lot of people have probably heard of drugs like Imigran and Maxalt. Those triptan drugs act between where CGRP is released and the blood vessels expand to kind of block that process from happening. Ergotamine, which is an old drug that the triptans largely replace, but which some of my patients are still on, is important at shrinking back down the blood vessels. And caffeine actually works here as well to kind of shrink blood vessels back down. And then you've got those things then secrete pain molecules from the nerve endings of the blood vessel nerves that are sort of throbbing away. And non-steroidal anti-inflammatory drugs and paracetamol can soak that up. So I usually use a combination of these things to manage an acute attack for an individual patient. So I use an anti-migraine medicine like a triptan drug or ergotamine in combination with an anti-inflammatory painkiller. And some patients also need an anti-nausea drug. This is both to address the fact that their stomach is paralyzed, so drugs may not come from the stomach into the small bowel reliably. You'll see that in a patient who sometimes their drugs work really well for their migraines and other times they do nothing, even though they're taking them right at the beginning of the headache. That means that their stomach is sometimes paralyzed and the drugs are just not being delivered properly. So some of the anti-nausea drugs help the stomach to empty, but also nausea and vomiting is severely disabling. And if I can treat that, I'm doing well. And then what can you do to help yourself? Well, there are a whole lot of myths that I think I'll spend a little bit of time disbanding, because I think these are things that make headache sufferers' lives more difficult than they need to be. And the things that we've all heard before. Maybe some of you have had good experiences with these, but I think using this as your primary strategy is probably not really a solution. So firstly, avoiding triggers. Well, some people have extremely reliable triggers. So personally, I haven't consumed alcohol in about 15 years because when I do, it is just not worth it. I get a terrible migraine. It can last for over a week. And it's just, I cannot think of anything worse than that. So I'm not remotely interested, even though I used to love drinking wine in particular. It's just not for me, and that's fine. So some people have something like that that's relatively easy to avoid. And, you know, like maybe chocolate is not something you can have during your period or you get a migraine. You know, it's something really, you know, self-contained that you can deal with. But then what I see far more often is patients who have been on really extreme elimination diets to try and, because they believe that their migraines are caused by something, and they're maybe 20% better on this diet, but it's sort of giving them a sense of control over their illness. And so they haven't had like 20 different essential foods that are part of a normal diet for years and years. They have a really, you know, the other thing I see all the time is people who have reduced their commitments very significantly. So, you know, have given up work or work part-time. Sometimes it's necessary, but it's necessary far less often than actually occurs. And whilst in the short term, till the migraines are under control, that may be necessary, it should not be, you know, if you've got a really high stress job with lots of detailed tasks, it usually is not necessary. And I would advise people against making drastic career changes or really reducing their commitments most of the time. The other thing is a lot of people think, oh, I'm just really stressed out right now. You know, my mum's sick, my kids are stressing me out. I'm just going to wait for a less stressful time and then I'm going to deal with my migraines then, which is not necessarily great, because what about all the people that get to be stressed at work and stressed at home and not have a migraine to deal with on top of that? Maybe it's time to cut yourself a break and get yourself sorted out now. The other thing is, again, with the, you know, similar to avoiding triggers, having a punishingly clean lifestyle that you can sustain for maybe 3 to 6 months, but you're never going to be able to do it for years. Or a lifestyle that's so clean that it just makes you miserable because it doesn't leave any time for socializing or eating things that you love to eat and things like that. That's just not worth it either. Getting pregnant, more often than not, people avoid pregnancy because they're too afraid to be able to care for kids properly in a state where they need someone to care for them. And waiting to go through menopause works a lot of the time, but usually perimenopause is really bad. And a lot of women don't get better with menopause, and some women even get migraine for the first time in menopause. So it's not, you know, a man is not a plan and menopause is not a plan, basically. So what can you do that is based on evidence that will help you? Well, if I had to summarize all of the advice I'm about to give about these three things, moderate would be the advice. So everything needs to be kept kind of even and chilled. Now, does that mean that, the 16-year-old kid with migraine, when they're, between the ages of 16 and 21 isn't going to go out partying and having a great time, or that they shouldn't do those things? No, like we all have to live normal lives. We all have to achieve things other than having a migraine in our existence, and those things are important. But the more you can keep things regular, the better your migraines are going to be. Physical exercise is essential, although one of the great punishes of this whole thing is sometimes physical exercise is really difficult to do when your migraines are poorly controlled. And the other thing is migraines are anxiety provoking. You have an unpredictable illness that can play up at any time and hugely disrupt your life. It is no surprise that a lot of people with migraine suffer from anxiety and depression, and managing those two things well is absolutely key to having a good quality of life, because if you're depressed or if you're anxious, that's going to make living with your disease much harder. It's going to make each migraine attack more disabling as well. So with food, most important thing, don't skip meals. It's a really common trigger. Heaps of people with migraine have all kinds of other lifestyle things they're trying to achieve so they can be healthy again and not get migraines anymore. But I find diets like intermittent fasting, having really extreme paleo diet so you can't readily get food if you're hungry, avoid hunger, don't overfill yourself, but avoid being hungry, avoid skipping meals. The other thing is there is heaps of research that shows that people with migraine have less healthy diets than people without migraine. And some of that might be that some of the migraine electrical activity actually can make people crave sweet foods and things like that. So one of the best things you can do before you look into really exotic diets that will help you, and there is some evidence for paleo and omega-6 rich diets, low in omega-3 and all of this kind of stuff. But far and away, what most of my patients need is just to have a normal, balanced, healthy diet. And like a really, not vanilla, like it has to be delicious, or food should be, but, just start with really basic stuff. If you get the basic stuff right, and then you want to launch off into a really unusual diet, go for it. Drinking enough water is really important. And I think probably the biggest barrier I see with this is people with continence problems. There are strategies you can use that help with that. So drinking most of your water, like a large amount of it at a time when you know you'll be at home and things like that. But often that really interferes with people wanting to be hydrated enough. Avoiding foods that are excessively salty or sugary in most of your diet is also helpful. In terms of substances, alcohol is a common trigger. It's also toxic to your brain and nerves, but not if you don't consume it in excessive quantities. Caffeine is really helpful for migraine attacks because it shrinks blood vessels back down to size. But if you consume it regularly at irregular intervals or large amounts of it, it will increase the amount of migraines that you get and how severe those migraines can be, and also interfere with sleep, which you need. Smoking is no good for migraines or many other aspects of your health. And cocaine acts on blood vessels, which is one of the reasons that it causes strokes and is like a bit unsafe generally. But also it can really cause some problems with migraine. So if I had to choose an illicit drug that I didn't want a migraine sufferer to use, it's probably cocaine. Other supplements, so there is some evidence for vitamin B2, coenzyme Q10 and magnesium supplementation, but I would advise you to use this like a drug. So when I trial these in my patients, I trial them one at a time, and if it doesn't work, I get rid of it and I try the next one, because the less pills you take when you're well, the better you're going to feel. The less the patient you'll feel, the more of a normal human you're going to feel at the end of the day, and that is worth a lot. Sleep, it's the most important piece of advice is to keep consistent sleep and wake times and give yourself a 7 to 9 sleep hour opportunity per night. It needs to be more, like teenagers need more sleep than that, but for a regular adult, that's the usual range. And also don't sleep in or take afternoon naps. It's a really common trigger. Exercise consistently and to the greatest extent that you can. And if you're having trouble exercising as part of your headache management, you need to tell your neurologist, because you need to work specifically with medications around exercise management. And according to the research, cardiovascular and weight-bearing exercises are the best. I was really disappointed when I found that out, because I love yoga. I just think it's so great, but it's actually, there's not a lot of evidence for yoga and migraine.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. But otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.